Good morning. I'm Rhonda Smith, the Executive Director of the California Black Health Network, and I would like to welcome you all to today's ACEs Aware Provider Engagement event, the impact of ACEs on Black maternal health. So thank you for taking time out of your busy weekend, I'm sure, and your Saturday morning to be with us here today. We are an ACEs Aware grantee, and we are bringing this event to you today in conjunction with the initiative statewide activities and the support of our partners, Arera Health and the California Black Women's Health Project. In California, as in much of the rest of the country, Black mothers experience the highest rates of maternal mortality and morbidity than any other racial or ethnic group. Despite the improvements in maternal health for all races, in California, Black mothers continue to experience 3 to 4 times more likely deaths than other racial groups from pregnancy and birth-related causes, and twice as likely to suffer from maternal morbidity, such as hemorrhaging and infection and the like, much more than any other group. Now, we aren't here today to solve this problem, but what we hope to accomplish is to acknowledge the role of toxic stress and trauma on Black maternal health and how we can perhaps mitigate that as a risk factor for Black pregnant women. Before we begin, and in light of toxic stress and trauma, I'd like to take a moment to say to our AAPI brothers and sisters who may be in the audience today that CBHN sees you, we stand with you in solidarity, and we are here to provide support in any way necessary through this unfortunate crisis. Before we begin, just a few housekeeping things. Most of your videos will be turned off except the speakers. You will have an opportunity to ask questions. Please put those questions in the chat box. You can do that throughout the presentation, and we will have a designated question and answer period at the end of each speaker's presentation. So just a disclosure, today the California Medical Association is providing the CME credit, and none of the faculty or planners for this educational activity have any relevant financial relationships to disclose with ineligible companies or organizations whose primary business is producing, marketing, selling, or reselling or distributing healthcare products used by or on patients. So this activity has not received any commercial support. We received some inquiries before, so I assume that some of you who are present today may have some questions about this, but the California Medical Association is not a CE provider for nursing. If you are a nurse and want to claim Category 1 credit, to the extent that your board will allow, then we recommend that you inquire with your board to determine if you are eligible for any claims for credits today. We have 2 certificates for the participants today, one for physicians and one for non-physicians. Nurses and any other allied health professionals wishing to claim credit for their attendance today and participation can use the non-physician certificate to do so. So just a picture of what will happen today and the flow. We will have 3 plenary sessions presented by our speakers today. Dr. Clark will go first, and she will focus on the impact of racism on health, epigenetics, and toxic stress, and what that really means for Black pregnant women. Dr. Silas Young will focus on toxic stress and trauma and how that can impact mental and physical health and predict health outcomes. And then Dr. Stecker will talk about the effects of toxic stress and implementing ACEs and resilience training into practice. So tools and techniques that you can take away and use in your practice on a day-to-day basis. And then we'll have some interactive discussions through the breakout sessions, and then we'll come back to the main session and wrap up and close for the day. So just a little bit of background about the California Black Health Network for those of you who may not be completely familiar with the organization. We were founded in 1978 and became a 501c3 in 1983 and established as a statewide organization. So the California Black Health Network has been in existence for more than 40 years. In the beginning, it was a chapter and affiliate model that doesn't exist so much anymore, but our claim to fame and some historic moments in our history have been assisting with the creation of the Office of Multicultural Health and also a co-founder of the California Pan-Ethnic Health Network, otherwise known as CPEN. So who we are is we are the voice and trusted resource for Black health equity in California, and we are the only Black-led statewide organization here in California dedicated to advocating for health equity for all African Americans and Black immigrants across the state. And so I'm honored today to present Dr. Melissa Clark. She is a Harvard-educated physician. For over 20 years, she has been practicing on the front lines and educating patients about taking an active role in their healthcare. Through her various roles as a healthcare leader with doctors, academic hospitals, and insurers, Dr. Clark has been seen to empower patients and healthcare consumers to best care for themselves and get the highest quality healthcare. With her extensive knowledge of healthcare, she has been an author in numerous publications and a commentator on radio and television shows. She hosts a weekly Facebook and Instagram live program called Real Talk with Dr. Melissa Clark, and is a weekly medical contributor on the nationally syndicated Russ Parr Morning Show on Radio 1. You can follow her and subscribe to her social media where she answers your questions and provides valuable health commentary that empowers us to take care of our most valuable resource, our health. Welcome, Dr. Clark.
Thank you so much for having me. And I will go ahead and share my screen. All right. So thank you so much for Rhonda for extending the invitation to be here today. I'm honored, and even though I'm joining you virtually, my bio didn't say I actually went to University of California at San Francisco. So sort of being a part of the California Black Health Network is something that I feel very honored to have been asked to join this panel. So, you know, as in your opening remarks, we have an American maternal mortality crisis that's happening right now. And that's largely due to the fact that maternal mortality has been increasing in the United States over the past few decades, whereas it's been actually going down in other countries. And we see that among African American women, U.S. maternal mortality is 2.4 to 3 times higher than that of their white counterparts. And at the same time, that mortality gap is actually increasing as Black women age. And why is this? You know, it's actually multifactorial. Black women experience disparities at higher rates. So we see that from an economic perspective, Black women make 63% of what white men make in the workplace. And that's in contrast to white women who make 82%. So even though there's a gender gap, there's an even greater racial gap. And then when it comes to health conditions, we see that African American women have higher rates of diabetes. African Americans in general are 60% more likely than whites to be diagnosed with diabetes. And then, of course, with preeclampsia, maternal hemorrhage, those rates are higher as well. And then when we get to health care disparities, so health conditions or health disparities versus health care disparities, which are the disparities in delivery of health care. We see that African Americans have higher rates of lacking insurance. And even when they do have insurance, if it's public insurance, such as Medicaid, a lot of times health systems and even at the level of the individual physician discriminate against taking public access insurance like Medicaid or Medi-Cal. And so that leaves the pool of available physicians available to these to African Americans and other marginalized communities as being much lower. A lot of times the concentration of high quality hospitals and high quality providers in communities of color is much less. And it's more difficult to actually reach them and get to them. And then there's the treatment that African Americans experience once they try to access the healthcare system. Numerous studies have documented that Black women are undertreated for, or Black people in general are undertreated for pain get fewer referrals in the healthcare system to life-saving treatments like heart catheterizations or renal replacement therapy, etc. And then, what the actual individual experiences when they experience that healthcare disparate treatment is a sense of disempowerment and further mistrust, which compounds the historical mistrust that we as African Americans know because of the Tuskegee study, for example, or forced sterilization of women in the 1920s through 1950s throughout the country, but especially Black women in North Carolina, or the fact that Black women's bodies were used during slavery to experiment on, to just learn female anatomy, and numerous surgeries were done without anesthesia and without consent, only for that purpose. And so because of this disparate treatment, we see Black people and Black women lacking a sense of agency when it comes to healthcare, feeling disempowered in terms of trying to access the healthcare system. Yet, in a New York City health department study showed that it's not just economics. A college-educated African-American woman is 3 times more likely to experience severe maternal complications than a white woman without a high school education. And the root of this is in terms of the policies and how we're seeing things play out in today's society and today's healthcare system started in the 1940s with redlining. It was the root of modern day housing segregation, which set up differentials in the quality of care and access to care and economic conditions in neighborhoods that reverberate today. This was started in the 1940s when the Federal Housing Authority refused to back loans, housing loans made in predominantly African American neighborhoods, which led to increasing segregation and lack of opportunity available in those neighborhoods. Poorer quality schools, less jobs available, less reliable transportation going to those neighborhoods. And we know from numerous studies that where you live is a huge determinant in how healthy you are. And we see that 80% of healthcare outcomes can be traced to your zip code. These social determinants of health, where conditions where people live, learn, work, and play, are linked to structural and systemic racism and have prevented African Americans from having fair opportunities for health, which is what we call health equity. And we know the COVID-19 pandemic has really shown a light on that, but those of us who've been doing this work know that it pre-existed the pandemic, and that the pandemic only shone a light on it in very stark reality for those people who were not aware of it prior. Only 20% of health outcomes are addressed in healthcare settings. And even those health behaviors, tobacco use, diet and exercise, alcohol use, sexual activity, even those are affected by your environment, which I'll go into in a little bit. I love this diagram. This is by Dr. Wendy Ellis, who talks about the effect of adverse community environments, such as what we've been talking about: poverty, discrimination, lack of opportunity and social mobility, poor housing quality and affordability, violence, magnifying adverse childhood experiences, which are those experiences that you see that can go untreated and cause increased risk of chronic disease and poor health outcomes in adults. And it's not just the events in childhood that lead to these poorer health outcomes in adults. This toxic stress that ACEs create can occur when a child experiences strong, frequent, and/or prolonged adversity. And the key is without adequate adult support. That prolonged toxic stress can disrupt the development of the brain architecture and increase the risk for stress-related disease, premature aging, and even addiction well into the adult years. When we're overwhelmed by stress, this begins a cascade in our body of 1,400 biochemical reactions. Stress activates our fight or flight system, which is not the state in which we can really create new healthy cells in our body, which leads to a cascade of chronic inflammation. We know that chronic inflammation is linked to a multiplicity of diseases in adulthood. And then remember when I talked about those behaviors such as smoking and alcohol addiction, etc. It turns out that there is a relationship too with environment. So we know about the chemical dopamine. Dopamine is released in our brain, and when the biochemical reactions that lead to an increased release of dopamine are in harmony with each other, we have adequate dopamine releases in relationship to experiences that we go through in our life. And when we have a positive reward experience, we feel happiness and joy as related to the balance of dopamine in our brain. When these chemicals are out of balance, though, dopamine does not end up being released in adequate amounts, which can lead to a situation where we feel that we have to do increasing risky behaviors to get that same sort of high that we would normally get from sort of your average positive experience. And this is all done based on the work of Dr. Ken Blum. And he has been able to show that there are certain genetic variants where we have fewer dopamine receptors in our brain, or fewer neurotransmitters, such as on the previous slide, serotonin, etc., that are being produced. And so that's a situation that you might be born with. However, for the majority of people, it turns out that if they're undergoing toxic stress, chronic stress that's untreated, this can actually lead to modification of your existing genes, which might have been the variation that allows for balance when you were born. But that repeated exposure to toxic stress can cause a downregulation or less production of the dopamine receptors. And so you end up with this functionally lower dopamine state. So therefore, you need to have increasing outside stimulation that can potentially lead to addictive behaviors. So things like chemicals like nicotine or alcohol can sort of, marijuana can help to compensate for this low dopamine state, but unfortunately may lead to addiction. And again, that could be for food as well. And then lastly, I want to also touch on the fact that toxic stress through epigenetics can affect the health of subsequent generation. Again, epigenetics is the modification of our genome, of our genes, in terms of turning them on or off, their actual function, not the structure of our genetic material. And so we see this example that was published in the National Academy of Sciences in 2008, where they saw that people who were exposed in utero to the Dutch famine of 1944 to 45 had alterations in their IFG2 gene, which plays an important role in insulin metabolism and human growth. And that was in people 60 years later, in the children of the women that went through that experience. They had a higher rate of health problems such as obesity, diabetes, kidney damage, and even heart disease. And in addition, we see that individuals who survived the Holocaust, their descendants had a modification in the FKBP5 gene, which they have observed that those descendants have higher rates of PTSD, hypertension, and obesity. That particular gene is involved in regulating glucocorticoids and the immune system. So we've seen that toxic stress can have effect on developing brain architecture, the release of chemicals, and even be passed on through health effects to the next generation. But then, if that generation experiences differential stress in their life, it actually can alter the genetic structure itself. So, we've seen a lot of work that shows that uh, the phenomena of weathering, which is this differential exposure to toxic stress that can cause wear and tear on our DNA. And the part of the DNA that we see this in is the telomeres, those end caps on the DNA that keep it from unraveling. And every time they divide, they can be damaged and shortened over time. So, shortened telomeres are correlated with chronic disease and premature aging. We see a 25% risk of earlier death among people with the shortest telomeres. Lots of studies have been done on this in looking at African Americans and shortened telomeres. We've seen that African American men who report experiences of racism, but who internalize those experiences of racism, have shorter telomere lengths as opposed to those who don't internalize it and it does not affect their self image. Their telomeres are unaffected. We see that Black women aged 49 to 55 were on average 7.5 years biologically older when you look at their telomeres in terms of the length than white women of the same age. And that work was done by Dr. Geronimus, who developed the theory of weathering. And interestingly enough, weathering is not related to poverty alone. So she looked at 239 Black, white, and Mexican adults living in Detroit who were of low to moderate income. And she showed that white residents' telomere lengths correlated with income. So the shorter telomere length was associated with those in poverty, in greater poverty. Um, Conversely, interestingly enough, Mexican residents had the opposite correlation. Longer telomeres were seen in people in worse economic conditions. And it was thought that I'll get to that later. And then African American residents had equivalent telomere lengths regardless of income levels. And the interpretation of that was how others in your environment treat you based on race is not necessarily something that financial security can change. And it harkens back to that statistic I said on an earlier slide about college educated Black women having worse maternal outcomes than white women without a college degree or without a high school degree, actually. Um, and so we see this sort of prolonged psychological stress on African Americans due to racism at any income level. And a 2017 Journal of Medicine study looked at over 1,000 African American women born in the United States versus those born in Africa, and found that those who recently immigrated had lower rates of preterm birth than US born Black Americans. And I think that that might also account for what we see with Mexican residents who that those who more recently arrived may have lower rates and longer telomeres because of less exposure to racism in this country. And so we have a number of challenges in reaching health equity when it comes to maternal outcomes. Number one, birth outcomes worsen among African American women as they age because it's not just economics, but racism and life trauma. Healthcare providers must recognize the role of toxic stress in all aspects of health, but especially on maternal health. Increased access to culturally competent mental health care is so important to help us avoid the effects of internalized racism and toxic stress. But sadly, right now, in terms of access to mental health, you know, due to the barriers due to insurance or having insurance that doesn't cover mental health, which has been taken care of largely by the Affordable Care Act, the fact that culturally competent Mental health care is hard to find. Only 4% of psychologists, 1% of psychiatrists are African American, and we are 13% of the population. And only 1 in 3 African Americans get the mental health care that they need. And then lastly, increased access to culturally competent perinatal care that takes into account ACEs and toxic stress are greatly needed to improve maternal health outcomes. And of course, if we eliminated racism, all this might be a moot point. I'll be happy to take questions now. And you can see how to contact me on any of my social media handles or through email.
Yeah, thank you so much, Dr. Clark. As always, you always share really provocative, wonderful information. So this is maybe not so much a question, but someone says looking at the research points to brains lower in dopamine, and I can't help to think about the idea that there is more susceptibility to depression and the correlation between mental health and physical health outcomes.
I think that is an excellent observation. And a lot of times, the self medication that happens because we don't have access to mental health care then translates into substance use, which of course is toxic on any level, but especially toxic to maternal health.
Yes, and so I wanted to point out a couple of things that you mentioned, and maybe we can have a little bit of a discussion or dialogue about this. And so in the beginning, you talked about really the dark history of trauma and mistrust of the medical system that is, somewhat prevalent in the African American community. And you kind of touched upon generational trauma, but can you go a little bit deeper in terms of its influence on the health of African Americans and potentially health outcomes?
Absolutely. So I think that generational trauma refers to the slide where I was talking about the effects of the Dutch famine and what happened in the Holocaust. But as you know, we as African Americans have endured in this country 400 years of generational trauma that started certainly with capture in the West African and Southern African countries, but then persisted through the Middle Passage into enslavement, into Jim Crow and lynching, into the redlining that I talked about with decreased economic opportunities, microaggressions, police brutality, and the fear that we have today. And that's I can't help but reflect on, as you mentioned at the very beginning, the unfortunate and terrible circumstance that just happened in the Asian American community and what they've been dealing with for COVID, with COVID and the discrimination that has happened. Those kinds of traumas untreated, what African Americans have been dealing with all this time, are things that can therefore get internalized, have an epigenetic effect, and potentially then be passed on to other generations.
Great. So we do have a question from Murray. How can mental health professionals collaborate with medical professionals to support this population?
Yeah. So, my area of concentration is population health. And population health really talks about what kind of interventions are needed and how can the healthcare system be transformed to really adequately provide that whole person care that every individual deserves when they interact with the healthcare system. So, I was fortunate enough to be involved in putting together a telehealth model where when people come for primary care, they actually can get linked to a variety of services at their primary care provider's location without ever having to leave. And one of those that easily fits into that model is mental health. So if you screen in your practice as a primary care provider or an obstetrician gynecologist, have relationships with psychologists and counselors and social workers and psychiatrists, where as you identify issues, you can schedule your patient on their next visit, or even now that telehealth has proliferated for a telehealth visit with a mental health provider. Um, for those people who don't have access to telehealth at home, you can set it up in your office such that they can come when they come for their visits to actually have the second half of their visit be with a mental health professional just to make it easy to improve access.
Great. So before I move on to the next question, I just want to give acknowledgement to how important social workers are in providing culturally competent care.
Yes.
So thank you, Amber, for bringing that to the forefront. So the next question is, how does racism and life trauma put African-American pregnant and postpartum mothers at risk for maternal mental health conditions?
Wow, that's an excellent question. And before I answer it, I just want to jump back to social workers. Social workers knew about patient-centered care and everything that we're talking about way before the um, mainstream medical system adopted it. And the only reason we've adopted it is because economic incentives are now linked to health outcomes, and we've had to therefore expand into this whole person aspect of care that social workers have been doing all along. So salute to them. Um, so as far as postpartum depression, we definitely see increased risk of postpartum depression, which is defined as any depression that exists actually a year out from um, the actual from birth. And I think all these things that we've talked about in terms of affecting physical health and mental health, all these adverse childhood experiences and toxic stress can't help but add to the risk of increased maternal mortality. I remember my very first patient at UCSF when I did psychiatry was a young woman who had unfortunately been accused of killing her baby, and she was African American. Evaluated for postpartum depression and postpartum psychosis. And she had experienced all these, at the time as a medical student, I didn't know about this, but in retrospect, she had experienced all these adverse childhood events that we're talking about. So yes, it's an unfortunate correlation, and one that I'm sure that we're going to get into as the day goes on with the other panelists.
Great. I think this is another question from Robert, and probably a totally separate session that could happen. But the question is, are public welfare policies a reflection of systemic racism?
Yes. I think the pandemic has shown us that there is money at the federal level to increase Medicaid payments and make them on par, at least, with Medicare payments. But historically, those payments have been disparate, which has led to, as I mentioned in my talk, uh, uh, providers and hospitals cherry picking and saying, oh, well, we don't take Medicaid patients because the reimbursement is not there. And then there's this other phenomena that is happening where incentives, as I mentioned, incentives to improve health outcomes don't take into account um, the increased resources that are needed in marginalized communities to realize those outcomes. So therefore, providers then cherry pick those patients that they feel they will be able to reach the health outcomes and get the incentive payments for, and leave behind those people who they think it will be too challenging and too many resources needed. And so safeguards are needed in this sort of new population health system in order to ensure that doesn't happen. And there are a variety of ways to do that, but we have yet to see it adopted on a national level. So yes, definitely, and remedies definitely are needed in that space. That's part of the work that I do.
Great. Thank you. And this is something that we'll talk about in the subsequent presentations, but Leanne wants to know if you recommend ACEs screening for all pregnant women.
Absolutely. And I think one of my other panelists is going to get into that later on. But yes, not just screening, but as I mentioned, referral to mental health, so that the reason I mentioned that study about African American men is because it shows that if you don't internalize what happens to you, you may have at least not the same effects on your DNA, which then implies a lower risk of disease and chronic inflammation developing in your body. So, to the extent that we can identify the problem and help to treat it on a routine and standardized basis, I think that we will be able to have better health outcomes, and that research needs to be done.
Great. We have a few more questions. Let's see. So Nichelle says Geronimus has incorporated the study of allostatic load and telomere length into her own work. She recently led a study of telomere length in Detroit among low-income individuals of multiple races and ethnicities. The results suggest that community and kin networks may be more protective for health than income and education. Any thoughts or comments on that statement?
Yes. And I think, remember, we talked about the Mexican American population in Detroit having that protective factor. So, one of the explanations was that as Mexican Americans ascend in terms of economic well being, that they lose some of those protective kin relationships. And that's why you see the converse happening in terms of their telomere length. But yeah, that was a very interesting study, and her work is really groundbreaking and innovative.
Great. And Ure has another question. So aside from the Edinburgh postnatal depression scale, are there other measures or scales that can be utilized to identify symptoms for Black women?
I will actually leave that to my other panelists because I'm pretty sure they're going to get into that in terms of the identification and specifically how these things are applied in the maternal space among African
Yes.
American.
Yes, great. And so let's see if we have any other questions here. Lots of comments. So since there are no protective factors for Black women, such as income and education, and among other things, what is something that Black mothers can do?
Yes, I think that's an excellent question. So I think we heard about the kin relationships being protective. So building your social network as much as possible, close relationships. Number two, as I mentioned, talking to your healthcare provider about a referral for just mental health and mental well-being. And that can be just because of pregnancy. There are certain stresses associated with pregnancy. So even if you may or may not realize all these other stressors that you have on you, just the potential stress of pregnancy in and of itself can be one that can warrant a mental health referral. The other thing too is looking at the role of doulas. And again, I think maybe one of my other panelists may get into this, but having an advocate for you when you go to your visits, your prenatal visits, and when you go to deliver, if you don't have a supportive partner, and sometimes your partner might not be equipped to play that role, having a doula by your side, who knows the system, who knows how to navigate, who can advocate on your behalf, can also be a protective factor as well.
Great. So I want to, before we move on and wrap up your part, I would like to go back to something you pointed out in one of the previous slides, and that I think, at least from the work that we do, is so important. And you talked about policies that throughout history have been enacted, like redlining, and the impact that causes. And basically, we know that policies create inequities that in turn impact social determinants of health that ultimately lead to, or can lead to, disparity. So I thank you for bringing up the importance of social determinants of health and Also, the fact that where people live can often dictate how long they live and how well they live. And so, I can't stress the importance enough of your point around whole person care and recognizing that health really happens outside of the four walls of any healthcare center, and that there's a lot more happening in people's lives that show up symptomatically when people are seeking healthcare. And recognizing that, I think, is an important part of keeping everybody, all of us, healthy and well in the long term. So I think I have some additional questions in here. People are definitely supporting the idea of doulas.
While you're
Yeah.
looking for that, I can also say too that, um, the Affordable Care Act and setting up this incentive for the healthcare system looking beyond the four walls of the healthcare system really has sparked, I think, a positive movement for healthcare providers, not just to partner with mental health providers, as we talked about before, but also community-based organizations that are grounded in the community, led by community members, have their pulse on the finger of what the community needs are, and therefore can serve as trusted messengers. There's one, for example, that focuses on maternal wellness here in the DC area where I live, called Mama Toto. They're a nonprofit that provides services for African American and other underserved women when it comes to maternal child health. And the partnerships between healthcare organizations and organizations like that provide doulas, for example, at no cost to the recipient of services, are ones that I really think need to be incorporated on an ongoing basis, and reimbursement models for those kinds of partnerships need to be built into health policy such that those organizations can be paid from that incentive money just as much as the
That's a
health.
great, that's great. And so I'm curious as to whether or not you have been privy to any evidence-based information that demonstrates improvement in outcomes for doulas when they have been part of the perinatal process or health process for Black pregnant women.
I don't, but that doesn't mean it doesn't exist.
Okay. Okay, maybe some of the other speakers may be more acquainted with any studies or research. So, right, so unless there are any more questions, I think we can move on to the next speaker. So thank you so much, Dr. Clark. We really appreciated your content. And yes, so everybody will know this recording will be housed on the California Black Health Network's website. So going forward, it should be posted on the website within the week.
Thank you very much for having me.
Thank you. So our next speaker is Dr. Tanisha Silas Young. Dr. Young is originally from Vallejo, California, and completed her undergraduate coursework at UC Davis, where she was a student athlete on the track and field team. She also graduated from UC Davis School of Medicine and then went on to the University of Texas, South Texas Southwestern in Dallas, Texas, and completed her residency in obstetrics and gynecology at the Parkland Memorial Center. Afterwards, she returned to the Solano area to be closer to her family and to establish her practice. So she's been practicing at Kaiser Vacaville Women's Health Center for the last 10 years, where she has implemented ACEs screening into her perinatal care practice. She is the physician chief of the Kaiser Women's Health Department and the Napa Solano area Women's Health Physician ACE champion. And also important to note, on a personal matter, she's married to her college sweetheart and is raising 3 seemingly very active children, especially in COVID. So welcome, Dr. Silas Young.
Thank you, everyone. Thank you for that warm introduction, Rhonda. And good morning to everyone. That was a very informative talk that Dr. Clark just gave all of us and laid really the foundation for what we're going to be moving into in a moment. And really about how toxic stress and trauma is basically embodied and embodied in the individual, and how that can actually be shown to unfortunately have higher mental and physical health outcomes. untoward physical and mental health outcomes, and how also that trauma can be passed along through epigenetics into our family line. So that's the unfortunate side of things. And I hope you will leave here today understanding and knowing the hope in all of this, which is resiliency, which is basically the antidote for trauma and all of the effects of stress and toxic stress. And the fact that, honestly, resiliency has been shown to be passed along epigenetics into our family line as well. So trauma doesn't get the last say in all of this. And I think it's really quite fascinating to know that we in the field of obstetrics and gynecology in particular are really poised to be at the forefront of this movement to really help break generational trauma and toxic stress. Next slide, please. So I think it's really important to understand the origin of of this work. Trauma is arguably the biggest public health concern of our time. And it actually started in 1998 through Kaiser Permanente in the Southern California district or region. And Dr. Folletti is an internal medicine physician and was practicing in the obesity clinic, where he helped patients with morbid obesity achieve weight loss and good health outcomes. And he was speaking to a patient who all of a sudden gained just about all of her weight back. So he was trying to dig in a little deeper and figure out why this would have been so. He got really curious and started asking, basically taking a really good social history. And he meant to ask a patient, what age were you when you first had sexual intercourse? But what actually came out of his mouth was, how much did you weigh when you first had sexual intercourse? And unfortunately, her response was 40 pounds. So that took him aback, as you can imagine. And he really beautifully stumbled into finding out this link, not only with that patient, but with many of those patients in his obesity clinic, and how trauma basically was linked to poor health outcomes. For whatever reason, even though this study was evidence-based and published, and the CDC also was a co-author, it really didn't gain a lot of traction until about 10 years later, where our very own California Surgeon General, Dr. Nadine Burke-Harris, who's a pediatrician, noted that emotional trauma linked to poor outcomes for her pediatric practice in the Bayview district in an underserved population in San Francisco. And she's been spearheading this work ever since. Next slide. So ACEs, are looked at, as Dr. Clark had mentioned, really as an individual ACEs. So you can have an individual ACEs score, adverse childhood event score, and then also community ACEs. And so for the individual ACEs, there are basically 3 types of ACEs. There's abuse, neglect, and household dysfunction. And most people have at least one ACE score, 61% of the population. 1 in 6 people have 4 or more ACEs. And in most areas of the literature, you'll see 4 or more as the criteria for having what we call a high ACE score. ACE scores 4 or more are linked to increased morbidity and mortality, and unfortunately show a 4 to 12 times increase in suicidality, depression, substance abuse, smoking, STDs, obesity, heart disease, cancer, liver and lung disease. Next slide. And just as Dr. Clark mentioned, ACEs are also found in community trauma. So an individual can have individual ACEs, but also community ACEs. So community ACEs is trauma that a person experiences outside of their household and is the collective trauma of a particular community. And some of the examples of this are community violence, the historical trauma and institutional racism that Dr. Clark mentioned, food and housing insecurity, poverty, high unemployment rates, no or limited resources for youth, et cetera. And so these all compound the effects of an individual's household or traditional ACE score. So it's important to, as Dr. Clark mentioned, not only get a sense for your patient's own individual ACE score, which is involved in the traditional ACE screening, but to take it into context with their community level of trauma they may be experiencing as well. Next slide. And so when reviewing the literature for how ACEs affect